it's clearly concerning to take these medications long term if the effect goes away. And so we've got studies that don't go any longer than a year, but we tell people that the drugs are going to be safe and effective, sometimes indefinitely. But when you actually look at what happens in clinical practice, that's not true.
Welcome back to Psychobabble, where we expose bad therapy and the liberal narratives that contribute to our poor mental health. I'm Hannah Spear. Today, I am very excited to introduce you to a fellow psychiatrist. His name is Dr. Joseff Witt-Doerring, and he is specializing in the injuries caused by withdrawal and psychiatric medications, the adverse effects of them. And he has his own clinic, founded in 2020. It's called the TaperClinic. You should go check it out. He has a very popular YouTube channel under that name as well. Welcome to Psychobabble.
Hannah, thanks so much for having me.
So first of all, we're going to do this in a very structured way. It'll be the first time. So bear with me, but I want to get to all the questions that you've asked. We're going to get through. We're going to hit the SSRIs, damages and tapering. We're going to talk about benzos, and we're going to talk about Ritalin. And then I'm pretty sure we'll do a follow-up. So then I'll hear your comments about that, and if you have any residue questions. And then we're going to do a members exclusive video on the link between psychopharmaca and mass murders. So now you know about that. Before we dive in, thank you so much for the support. Thank you for liking and subscribing. That really helps me a lot. I understand in these times why many can't upgrade their membership, their subscription, but it would help me a lot if you leave a rating, leave a comment on whichever platform you're using. Thank you so much. First, I'm really interested to hear from you, Dr. Joseph, how you got into this advocacy in the first place. Because if I understand correctly, you worked in the FDA. So please take it away from there. Just quickly, we're on schedule.
Okay. The really abbreviated version is I grew up and I really liked psychology. I liked philosophy. I liked self-help. That was the way in which I looked at the world, and I looked at your ability to improve your life. And so when I was in medical school, I thought psychiatry would be a good avenue to merge that love that I had for those subjects with medicine. But when I started my residency in the United States, that was not what I saw. Really what I saw was people getting diagnosed with checklists of symptoms, very little attention being paid to things that were going on in their life, problems they were having, very little attention to their physical health. And people were moving through a conveyor belt where they would, maybe get a questionnaire in the waiting room, or, a 2-minute evaluation where a doctor asks questions, and they just get put on medications. Intuitively, this felt wrong to me, because how can you try and fix something when you don't understand it? And you're not really understanding it when you're just diagnosing it with symptoms. And so I asked a lot of questions, and it made me very unpopular. I would ask my professors questions. How can we treat these people without understanding what's going on? How does it make sense to use psychiatric medications which mask symptoms and clearly cause tolerance, meaning they're going to wear off over time? And they would look at me like I was crazy. They'd say, Josef, these drugs are safe and effective. They've been approved by the FDA. And when I would keep on answering questions, because that would not satisfy me, they would almost be offended, like, haven't you gotten the memo? We don't ask those questions here. We simply accept this thing, and you must, one, you're rude, and you must be someone who's had a very bad upbringing and poor training if you would even think that you could ask these questions. And I mean, I was probably 26, 27 at the time, and I'm thinking, well, this seems like bullshit, but who am I? I don't really know what I really don't understand the research. And so I decided to become a drug safety researcher. And I went and worked for Janssen, which is the pharmaceutical arm of Johnson & Johnson. I studied psychiatric clinical trials there. And then I went and worked at the FDA as a safety, as a medical officer there, doing safety analyses and looking at the evaluating research to let drugs onto the US market. And then I went back to the pharmaceutical industry. And long story short, I essentially got to see the evidence base behind psychiatric medications. And I realized what we were telling people about these drugs was not supported by the evidence. We were way off base. And so that's why in 2020, my wife and I, also a psychiatrist, we, at that time we decided that there were a lot of problems with medications, and there's also a lot of problems coming off of them, which I know we'll talk about. We felt that there was a strong need for a practice who could help people get off these medications. And so that's the sort of the story.
That is so interesting. So you've really been behind the scenes, but also in the clinic. And I recognize what you are saying. That is a faux pas to mention the faulty research, because if you look at the meta-analysis of the SSRIs, so now we're just going to start talking about the SSRIs. They're very clear that the efficacy is low.
Yeah. So I think. If we look at what the data shows, Irving Kirsch was one of the researchers who really looked into this. And when he did his analyses, they found that when you look at the difference between the group who gets the antidepressants and the group who gets placebo, on average, there's a 2-point difference on a 52-point scale. And we're talking about an incredibly modest effect, average effect. Mm-hmm. Now, there's going to be some people who'll have a stronger effect, some who won't. And to sort of cut to it, I've taken Zoloft before. My wife has taken it as well. We tried it when we were in our training to see what it was like. It has a clear drug effect. I think most people who take these medications will know they're emotionally constricting and they're blunting. It's clear as day. And so this is the effect that shows up in the clinical trials when there's this average difference. But the thing that most people don't realize is none of these drugs have been studied with placebo controls longer than about a year. And now, why is that a big deal? So let's say you don't care that, a drug, you don't really mind how the drug works. It blunts emotions, and that can help people who have a lot of anxiety or even depression. So what? Whether you believe in that philosophically or not, you might be okay with that. But the obvious problem with psychiatric medications is that they cause tolerance. Our bodies, they do not like to be in a drugged state. Our neurotransmitters do not affect, just our mind. They affect our heart and our gastrointestinal system and our immune system. And so when we disrupt those things with chemicals, the homeostatic mechanisms of our bodies kick in and they fight against the drugs. Now, it is with all kind of drugs that act on the mind, they cause tolerance, and so the effect wears off. Now, the issue with this is it doesn't really, it's clearly concerning to take these medications long term if the effect goes away. And so we've got studies that don't go any longer than a year, but we tell people that the drugs are going to be safe and effective, sometimes indefinitely. But when you actually look at what happens in clinical practice, that's not true. You put someone on a medication, they don't sail off into the sunset and they're fine for the rest of their life. They come back in 12 months, 18 months, and they need a higher dose. And then, and so on and so forth until you end up sort of maxed out, and then you end up on another medication. And so there's also this part of it that people don't, that they're not really told, that you may need to go higher and higher and be exposed to more side effects. And then there's the whole other issue of neurotoxicity over time, whereby most psychiatric medications can actually just make people sick in the long run. They can cause a whole range of worsening mental health issues just by the toxic effect on the brain. And that's another thing that no one really tells you about. And
we have studies on this, research showing this effect?
There's not any studies on it because they would need to be really long. But if we were to go through what the side effects research shows, like for instance, like if you look at antipsychotics, they can cause a condition called tardive dyskinesia, which is a permanent movement disorder. Happens in about 5% of people per year if you're young, and it's about 15% if you're older. And so that's permanent neurological damage for some people, highly correlated with cognitive decline. And so that's the antipsychotics. When you look at benzodiazepines, they make people more anxious in the long term.
Yeah.
It causes a condition called bind as well, benzodiazepine-induced neurological dysfunction, where the people they become highly anxious, they develop cognitive impairment, and sometimes neurological symptoms. If you look at lithium, people can develop a condition called silent syndrome, which is an irreversible cognitive impairment that does not go away. And then when you go to the antidepressants, like the SSRIs, some people report developing this state where they feel very blunted, and so they feel disconnected from their life. They have high background anxiety as well, and they have no motivation for anything. Now researchers have called this tardive dysphoria, and I see it a lot in my practice. And it's not just psychiatric drugs. When you look at people who use cannabis for long periods of time, or alcohol for long periods of time, or methamphetamine for long periods of time, all of these things can lead to cognitive impairment that turns up on brain scans or in neuropsychological testing. And so I would say it's almost a rule that if you're exposing yourself chronically to drugs that act on the mind, a proportion of people will end up with some form of neurological impairment. And so that's what I'm seeing as the pattern among these medications.
Okay. So you also work clinically, obviously, in your training. Were there, in which cases did you see that the SSRIs could work? Could you distinguish the type of patients? Were there cases where you thought, okay, this was a good idea?
Yeah. So the way I think about these medications is they don't fix any underlying problem. As with all psychiatric conditions, there's no chemical imbalance or finding on a brain scan or something like that really consistently is seen, and that's why we don't do any testing or imaging in diagnosing these conditions. And so these drugs, they work by disrupting your neurotransmitter systems and inducing an effect, right? And so you really want to think about, when is a scenario where you would want to maybe just indiscriminately sort of suppress symptoms, right? And so I would never do that if, let's say, someone was suffering from a life stressor, their relationship problems, poverty, existential issues, they don't like their work. How would that ever be a good thing to do to someone, to sort of to blunt those feelings that are coming from legitimate things in their life? And so any life stresses, I would be really wary about putting them on a medication. Again, the next thing is, some people, when they have symptoms that come out of nowhere, they can be due to medical problems, which aren't diagnosed. Sometimes it could be obvious things like sleep apnea. Other times it could be gastrointestinal problems, things like celiac disease. Right.
Iron deficiency and women.
Iron deficiency. Yeah. Even things like vitamin D problems, and nutritional issues. So you need to address those. But if you're someone and you're feeling very depressed and you're feeling very anxious, or maybe you have OCD type thoughts, it does not seem to be driven by things going on in your life, and you've really worked on your physical health, you've optimized your lifestyle, you're not using drugs or excessive amounts of caffeine, you're moving your body, you've had a proper medical workup. If you're still having a lot of symptoms, you should be able to make an informed choice about whether you want to use these medications, knowing that the drug effect may wear off over time and you may need higher and higher doses. And so I'm only supportive of people using these medications after they've done all of the non-drug interventions and once they know the risks. And so if that's you, I think that's totally reasonable, and you can choose to do that.
Yeah, I also found that there's specific, if you have, you have these patients who have everything's in order, and no one on the outside would say, they don't understand why you're depressed or why you're so so anxious, and when they've done everything, they lack the confidence in their own competence. That's when I found that because it does work over the serotonin system, which has to do with confidence. And then when they're added that, I have with that specific subset of patients, I found it usually has a good effect. But it's a problem that they then use it as a crutch, that I rarely see people coming off of the SSRIs. You know what another thought I had, what I wanted your input is these, when you go to the research on SSRIs, they use these scales for these questionnaires to establish is there a moderate depression here or a severe depression. But in those questionnaires, you don't then categorize what we just talked about. What is the life stressors, how their lives are set up. So the problem is how we are categorizing depression as a disorder.
Yeah, and you're striking at the heart of the problem with the way we practice psychiatry these days. Is we have stopped asking the question of why is this person unhappy. We don't care anymore. Our diagnostic system is based simply on symptoms people are experiencing, and because of that, doctors don't make the effort to distinguish, hey, could this really be due to a problem in how they have relationships, or or something with work, and we need to go in that direction. We also have a very transactional medical system right now where doctors are incentivized to see people in shorter periods of time because they're not incentivized to make people well. And so many people simply do not get thorough medical investigations to make sure that their health is optimized, their lifestyle is optimized, that they're not harming themselves with substances and things like that. Doctors completely sidestep that. They go, who am I to motivate someone to try and actually fix their life? I'd rather just put them on this drug, tell them that they're depressed. That's much easier for me. And that's why we're not helping people with mental health problems. In fact, they're getting worse.
Yes. And so someone is on, it's most common, 20 milligrams of escitalopram. And they're listening to this like, that's me. I want to get off. Is that a common issue? What would you tell them?
Okay. So I would say that, coming off, is a good idea if you're stable. If things are relatively okay in your life and you'd like to come off, that's fine. It's also a good idea if you're having a lot of side effects and the benefits of the drug really aren't there anymore. In order to prepare for a taper, really you want to make sure you've addressed the underlying reasons why you got on the drug. Unfortunately, for most people I see these days, the reasons they got on the drug are very obvious. I went to college and I was studying engineering because my parents told me to, and I really didn't want to do that. I actually wanted to do something else, and I got on the SSRI. I moved towns and I was lonely. I went through a divorce. Someone died. A lot of the times people will get on these medications for very intuitive reasons. There's just problems in their life. And, maybe 10 years later, you might not need it. 5 years later, you might not need it. If that is you, then what is the drug really doing if your life has improved? So you could do a taper. But if you're someone where the symptoms come out of nowhere, you need to look at your medical health and lifestyle interventions. And you'd want to start there first. And if you can get to a place where you're not so symptomatic, then it's time to come off. As for doing the taper, the thing that you want to be aware of is that most doctors underestimate how hard it can be to come off these medications. And there has to be a little bit of nuance here. Many people, even if they've been on the drugs for several years, they might be able to come off in a couple of months without problems. I hear these stories every day from people. They just stop taking it and they're fine. The problem is that for some people, their brains are, I guess you could say, not very elastic. It's hard for them to adapt to the absence of the drug when it's removed, and they can have crippling withdrawal symptoms. And in some people, those withdrawal symptoms can almost lead to a brain injury that looks like a severe concussion that can last for a long period of time. And it's called protracted withdrawal. And I know this, if you've never heard of this, this probably sounds absolutely crazy. But if you go on websites like Surviving Antidepressants, you'll see hundreds of thousands of people on there who are trying to get through this. And this is what I specialize in. And so if you're this woman out there and you're on citalopram, what I would recommend that you do is that you convert the drug into a liquid, and then you use a syringe to gradually lower the dose of the medication. And most people who I taper, who have been on these drugs for several years, they're coming off in about a year to 18 months. If they want to do it without severe with only mild withdrawal symptoms. I mean, so when I do these tapers, my goal is that a person is able to work, they're able to live their life, they're not going to have, problems. I don't like the idea of just ripping the drug out and then sort of crossing your fingers and, clenching your knuckles and waiting for the severe withdrawal to die down. And so if you want to do it with mild symptoms that don't impair your ability to work or look after your family, turn it into a liquid, get precision syringes, lower it down gradually over a year or two. And if you go to the YouTube channel that I have, it's the Dr. Josef YouTube channel, we have lots of videos there on how to do this, and it kind of goes beyond what I can talk
and
to
they're
Hannah
really,
about
really
right
good.
now. Yeah.
I'll put the links below. They're very good, and you really do feel like you get sort of support on the way. That's what I really liked about you. You're so familiar and approachable. They're a great support. And then, okay, crazy. I've seen in the clinic that colleagues have prescribed benzodiazepines as a way of tapering smoothly. Do you want to comment on that approach? But you see where I'm getting at, that this is something that psychiatrists would do to sort of, but it's painful and I'm scared and I'm anxious about tapering. And then you get for 2 weeks a prescription for a benzodiazepine that you'll never get off.
I know. Yeah. I mean, for me, it's like, just taper slower. Like, what's the rush? And instead of doing that, they plunge someone into uncomfortable withdrawal, put them on a new drug that's even worse than the one they were taking before, and cause a new drug dependency, and put them at risk of one of these withdrawal injuries. And so it's just insane. I mean, it's really, really bad medicine.
Yeah. And that's so now I think we covered that. Now we're going to go over to talking about benzos. And that is, it's so. I was prescribed benzos when I was when I was doing my final exams and med school, and I was obviously anxious because it's difficult, and wasn't sleeping, and just like that, and I didn't really realize what it was. And it was just the ease with which I was prescribed this, and I took it and I was just sleeping. It's like, this isn't helping me. Like, I'm supposed to be studying and now I'm tranquilized. But this is something that so many people are taking some kind of benzodiazepine. So that's Valium, the Xanax. What are some other common names? People will recognize what we're talking about. Klonopin, yeah. So, do you want to say something about benzodiazepines, how you approach it? What do you see regarding that?
Well, I guess, I fell into the trap of benzodiazepines myself. After my daughter was born, this was around the time I was working at the FDA. I was also moonlighting to make additional money. And so I was doing night shifts. That's usually where you end up moonlighting. And my sleep was really poor. And, I was reading clinical trials all day. I was writing papers, and because
fun.
of that, I was, well, actually was fun. It was fun for me at the time, but it was very new because I was used to being a clinician, and now I'm doing this heavy research role. And I was using a lot of nicotine products. I was using chewing tobacco like all day. And I was drinking about, 3 cups of coffee and a couple Diet Cokes. Like
I also
really
did that during
not.
my training. Just like
Yeah,
chew. I'd never smoked a cigarette in my life. And then suddenly someone
yeah,
like, yeah, try this chewing
yeah,
nicotine now. It's such a good idea. I mean, the stuff we tell each other, really,
yeah,
doctors, heal thyself.
yeah. And I got my wife massively addicted to it as well. And she is beautiful and dainty and petite. And she used to carry around this bottle that she would spit into because she was chewing tobacco. And when I would get in the car with her, I would see her like spit her spit bottle in there. So we were a really bad influence on each other.
Sexy.
Yeah, yeah. Yeah, kissing with like the little like the residue in the teeth.
Oh
It's
my
just
God.
yeah, it's nasty
just
stuff.
crazy. We'd also take Seroquel
Yeah,
just to see the when I was working at the ward. We're like, have you tried Seroquel? Like
yeah,
it's so good that we just go right to
yeah,
sleep.
yeah,
Okay.
yeah.
Good times.
Well, yeah.
Good
So
times. Now we're
good
doing
times.
better.
Yeah, much better now. So obviously, my daughter's born. She's not sleeping well at night. I'm having a lot of. I'm not looking after myself, and my sleep is poor. So I start taking Xanax. I get it from a nurse practitioner in the US, and I'm occasionally I started just taking it on the nights after my overnight shift when I needed to reset my schedule. But very soon, I start taking it every night, and this was just for insomnia. And 6 months later, I had such bad anxiety from it. I actually developed obsessive thoughts. I would be sort of sitting there at my computer, typing away, trying to work. And the most embarrassing and intrusive, memories from my past would like pop up into my mind. And I'm thinking, I'm going crazy. Like, what is this? And then I learned that's really common with benzos. And so I guess the first thing I'd want to say about them is that they actually, for many people, can make anxiety worse in the long run. You can develop new symptoms over time.
Yeah.
And they're really addictive because, Hannah, as you were saying, I mean, these things pack a punch. They can be quite sedative. They can get rid of anxiety. And it's so easy to take something that can make everything go away in 30 minutes. It's like, you're using nicotine products, or you're on too much caffeine and now you're wired at night, or you're anxious when you're crashing. I'll just take a benzo. Oh, I'm nervous about, this thing that's happening. I'll just take it. And so you've got this crutch, and it kind of feels good as well. It felt good to me.
Right.
And so all of a sudden you can get caught up into it. And so
There are
super
drugs.
addictive.
It's like uppers, then you need downers, then you need uppers. It's exactly like that. Yeah.
Yeah. But the thing that I really focus on now, and this is actually most of my clinical practice, and people are kind of surprised because benzos, they're a bit less common now compared to the SSRIs, but boy, do they cause withdrawal problems. And so this is the other main class of medications that can cause these severe brain injuries when people come off. And ever since the opiate epidemic, doctors have been really afraid of prescribing them, and they're actually cutting a lot of people off of them. And so we get people who are forced cut off. They're forced tapered over the course of 2 months, or they go into a detox, and they get seriously injured. And it's only been in the last couple of months that we had the American Society of Addiction Medicine update their clinical practice guidelines to tell doctors in the US that they shouldn't be doing that anymore, that they need to taper people at 5 to 10%
Properly.
a month. They need to go slowly. Unfortunately, many people don't know this. And so that's the most common reason people will come and find me, is they're being forced tapered off these benzos, and they're in hell. I mean, like crippling anxiety and cognitive impairment and neurological problems. It's really bad.
Can't sleep. I mean, benzodiazepines, they destroy your sleep architecture, your sleep structure.
And that's why they're some of the hardest drugs to come off. Same with the antidepressants. Anything that will suppress anxiety or helps you sleep, you're going to be dealing with the opposite on the way out, on the way off. Crippling insomnia, severe anxiety, and these symptoms are so hard to deal with that they can be disabling. And this is why, like, stimulants aren't a problem to come off. Like when you have to get someone off Ritalin or Adderall or something like that, people tolerate apathy and low motivation much better than they tolerate high anxiety and insomnia. Yeah.
Yes, I mean, insomnia is a torture method. People forget that. It's a
Hmm.
very, very effective one. It's and do after, if I'm not mistaken, after 3 weeks you can start hallucinating from
Yeah.
insomnia.
Yeah.
But what is I found tapering from benzodiazepines is a lot more difficult than from the SSRIs. How do you approach that?
So in general, same methodology. Uh, you should convert the medication over to a liquid, because it allows you to do more gradual reductions. And this is especially important at the end of the taper, and this holds true for antidepressants, antipsychotics, or benzos. There's a there's something very interesting about how these drugs disconnect from the receptors. And so if you imagine like kind of two neurons sort of sitting together, and the drug is acting in the space between the neurons, kind of hitting the receptors, there's a huge reserve of drug there. And so you could go from like 100 milligrams of a drug, maybe down to 50, and you've only changed the receptor occupancy by like 10% or something like that. And so on and so forth until you get down to the very low doses. Once you get to the lower doses, there's not a lot of drug reserve. It's just floating around in between. And then the receptor occupancy, the amount of drug binding the receptors, it starts to plummet. And so most people will find that when they get to the lowest dose that you can even get in a tablet, that's when withdrawing them becomes extremely difficult. And even if you were to quarter that last tablet, it's still not a smooth enough reduction for you to not have extreme withdrawal symptoms. And so there's a psychiatrist called Mark Horowitz, who talks a lot about this, and the whole idea is called hyperbolic tapering. And so you need to change the drug into a liquid at the lower doses. And I usually use these 1 milliliter syringes that have 100 little spaces there, and then you just
Mhm.
drop one space every day, and it allows you to gradually ease off without shocking your nervous system.
Over how long would you say at that the last part? How long do you do that?
It could be 6 months, could be a year. I mean, the last part
Yeah.
is really where a lot of the action is taking place, because
Mhm.
that's where the drug is truly disconnecting from the receptors.
Yeah.
Yeah.
Are there any other medications that you would consider adding if that last time is to not is just unendurable?
No, I mean, I wouldn't, because if it's unenjoyable, it means that you need to slow down the rate of reduction. I
Yeah.
mean, it is possible to come off the medications without having moderate to severe withdrawal if you just do it slow enough. Now, if the symptoms are coming from somewhere else, like if you've had one of the withdrawal injuries, the drugs aren't going to work on that, because once you've damaged your nervous system, people generally tend to have side effects. If you're having a lot of symptoms because things are happening in your life, or you've got problems with your physical health, they would be much better addressed at that level than with adding a new medication. And so
Yeah.
I almost never, I never would introduce one drug to help someone come off another.
Would you sort of orient yourself as to their life situation and then say, better we start tapering in 2 months or in half a year when you have a new job, when you...
Yes. Yeah, that is exactly the way to do it. Do not rush into something like a drug taper unless you feel like you've got the time to do it properly. And and there really isn't a rush, unless you're having some severe side effect, which most people aren't. Just do it when you're
Mhm.
ready.
Let's just talk quickly about Ritalin or Adderall. I'm very concerned because I see that everywhere. I see, I talk to moms all the time, and they're recommended this. They are powerless at the doctor's office, at the psychologist's office. They're told this is the way to go, and they have, because of brain chemistry, this has to be done. It's such a growing problem, especially for young boys. Yeah, what can you tell us about Ritalin?
I mean, I think the use of stimulant medications is, in many ways, it's a cultural problem that's been driven by a lot of marketing. And so when I say it's a cultural problem, and I'll speak to the US, it may be similar. It's probably less in some areas of Europe, but at least in the United States, we are a hyper competitive capitalistic country. I mean, in many circles, I mean, you know, you are your salary or what you do. You know, the first things you ask, you know, what do you do? It's the way people kind of measure up in these really competitive places, and the way this is borne out is that you have kids training to get into Harvard or Ivy League schools from, you know, from grade one. And so the pressure, you know, the social pressure is immense.
Yeah.
And so I think not everyone has a mind that is designed to sit in a chair and, you know, type away at a computer or do, this information work. Some people are a lot more physical. Some people do better, you know, with interpersonal skills. But what we value right now are people that can, you know, do well in these white collar jobs where you sort of sit behind a computer.
Yeah.
And
In the school system that you just have to get through at the age they tell you to start and finish. But what would you tell moms, you know, so because this very often happens to me, they come and say, yeah, we've been prescribed this, and how would you package that to warn them off, or to make sure that they're properly informed about this drug that they're giving their kids, they're about to give their kids?
what I would tell them is that these drugs don't actually improve your academic performance. They're behavioral. They make things that are boring to people seem more interesting. They make kids who are hyperactive stay still. And so this is a behavioral intervention to kind of keep someone, you know, doing something that's not really that interesting. It doesn't translate to better grades. I mean, that's what the evidence has shown. There's a big article on this in the New York Times about a month ago. I think it was "Have We Been Wrong About ADHD?" where a lot of professionals were coming clean about what the long-term evidence was showing from the MTA study. This was the biggest NIMH study into ADHD, and essentially they're finding, you know, there's no real improvements over time in the things that people care about. What they do see is that there's growth suppression, and the kids who take the medications on average were an inch shorter than the other ones, and that there's risks. I mean, I was talking to a gentleman on my channel recently called Cooper, who was boisterous, and, you know, he was put on medications as many young boys are, like when he was in school, and he went and started a whole career as a journalist until he had a lot of side effects from the medications and wanted to come off, and then realized he actually hated his job. And so there's also this opportunity cost of trying to, you know, being a square and trying to fit yourself into a round hole, where if you feel like you need to medicate yourself to fit the mold, how is that going to, you know, get you to long-term happiness if you need to be drugged to kind of fit a system? I think you'd be much better off finding something that's naturally interesting to you and suited to you, where you don't have to be on drugs. And these are drugs. I mean, like we use methamphetamine. It's called Disoxin in the US as a third line treatment for ADHD. There's nothing that different about these medicines from amphetamine like street drugs. So
right, but they don't know this, right? When I say that this is an amphetamine, that they're not this basic thing. They're not told that, and then they're also told that no, because you see, because the Ritalin is working on your child, that's proof that he has ADHD. Because if he didn't have the ADHD, the Ritalin wouldn't work on him in this way. Have you heard that? That is to sort of prove that because it works and it calms him, that's proof that he has the disorder.
Take some of your child's Ritalin. I mean, it will work on you. You know, that's what these drugs do. They make you more focused, and they give you more concentration. and you can sit down and you can do tedious tasks better. I think they can also make some people more obsessive. But it works for everyone. I mean, there's, like with any other psychiatric condition, there's no known biological or laboratory abnormality. That's why we don't use these things to diagnose people. And so it's a drug effect. And if you just sort of step back and sort of think to yourself, you know, in what world would sort of indiscriminately just putting someone on a drug that's kind of stimulating improve cognitive performance? I mean, our brains are very complicated. They are finely tuned machines, and I mean, it makes sense to me that that's why they don't see academic improvement in kids who are on stimulants. Because I mean, we're just disrupting cognition. You know, yes, it makes people sit down and more focused, but it doesn't do the things that people think it is. And these are often, and there's some really shady marketing here. I mean, they used to get Adam Levine, who was the lead singer of Maroon 5, to talk about how he had adult ADHD when they were trying to market that, and saying, you know, if I didn't get on my medications, I never would have been able to write my album. They would fund these like fake grassroots organizations out there that had a very biological slant to how they understood the illness, and they would get people to say, if it wasn't for this ADHD medication, my marriage would have fallen apart, or I would have been in a terrible car accident because I wouldn't have been able to pay attention to the road. And so even though none of the clinical trials show this, there's a huge marketing machine behind it where they will platform people who will just say, you know, it's this life-changing thing. So I mean, it's a disaster. I mean, I think we had like 17% of American boys have been diagnosed with ADHD now. I mean, this is not like
1 in
brain.
8.
It's
a crime that they're telling mothers that there's something wrong with the brain activity of their child, and so that's why they need this. And they'll say, you know, but I took it and it didn't have an effect on me, and that's because I don't have the ADHD. Well, they're very frustrating, these conversations, I'm telling you.
It is true that, I mean, if you are hyperactive, you're going to notice the drug effect more. It's the same with an antidepressant. If you're extremely anxious and you take an antidepressant, you will feel it more than someone who's not as anxious. But yes, it's, I mean,
but it's also we have different personality structures. We have different, you know, if you're full of energy and you're extroverted and you like doing sports and you're super curious, open to experience, and you know you're not going to want to do the same as the introverted conscientious person. We've forgotten all the things we used to know about personality. Now we just medicate it. We're medicating, like you say, everyone into this introverted, conscientious person.
Yes, that's a really good way of looking at it.
Great. Okay, that was it for the free episode. We're going to go to the members exclusive video, but thank you for your support. And if you are not joining us there, then see you next time. Here, have a look.
You know, people just saying, I guess, that I'm a conspiracy theorist, things like that, and you know, how dare I?
Definitely. And you're in good company.
Yeah. And then it came out the next day that this person was on leave from a long-term psychiatric hospital, and
classic.
And really, when you are committed to long-term psychiatric hospital, you are usually on an involuntary commitment order. You're usually on long-acting injectable antipsychotics.